Charles, thank you very much. It's a pleasure to be here. I got a chance to get in here, I guess, Wednesday night, and have been here for the last day and a half, and I've really learned quite a bit. I hope you guys are too from this, and hopefully the next 2 out of the next 3 lectures, it won't decrease the knowledge base too much. We're going to start with a talk on an initial approach to the patient with abdominal gunshot wounds. Listen, I'm not an expert. I really am not. An expert would be someone that hopefully would never make mistakes, would know all the answers. It's actually part of the fun of trauma, I think, because you never know what's going to come in. But I do get a chance to practice quite a bit in Philadelphia. These are some of the depressing stats from our city. I could go back another 5-10 years, and they really would be relatively unchanged. We have never seen the dramatic decreases in gunshot wound violence that places like New York City and Boston have. And, of course, these are just the homicide numbers. Many-fold are the increased number of patients who are shot, and in part due to trauma systems and trauma centers, and in part due to maybe poor aim, we get a chance to take care of these patients. So we're not going to discuss in this session, we're not going to discuss stab wounds. We're not going to discuss pre-hospital care. We are not going to discuss the management of specific injuries. You guys have a lot of lectures. Yesterday you had some. You have some more this afternoon. I know Juan is talking, I think, about pancreatic injuries. You've already heard about duodenal injuries. We're not going to talk about any of those in this. And believe it or not, someone from Penn is not going to talk about damage control in this session. What we are discussing is the concept of examining the patient, imaging the patient, rapidly synthesizing data in the trauma bay, making the decision of going to the OR most likely. For any residents who presented the paper competition over the last couple of days, if you're in the office for your oral boards, you're presented with a patient with a gunshot wound to the abdomen, your oral board examiners are going to want you to go to the operating room with that patient. So when I showed up at Penn almost 20 years ago, Mike Rotunda was there as one of my senior partners. He remains a good friend and a mentor of mine. And one of the many, many things I learned from him was this concept that trajectory determination equals injury identification. And I just added the word accurate. But if you really know anatomy and you can figure out where a projectile went in and either went out or where it landed, you can do a pretty good job at figuring out what's injured in those patients. So we're going to talk very briefly about patients and their presentations to the emergency department / trauma resuscitation area who have gunshot wounds to the abdomen. And in our environment, we have very short pre-hospital times. Many of these patients show up with little or no notification. A full 25% of our patients come either by private vehicle or police. They know where we are. They just bring people in, and we hear tires screech in the driveway. And as we are starting a resuscitation, our trauma pagers go off. It's very, very helpful. I have to say it helps to have some pre-notification. A minute, 90 seconds is a huge advantage just for everybody to get their universal precautions on to make sure that the team is protected, because our incidence of bloodborne diseases in our patients is very high. Many times the patients themselves don't know they have hepatitis or HIV. And the concept of assigning roles and making sure everybody is mentally prepared from going to a no-action environment to a huge amount of action with a critically ill patient in a very short amount of time. A 90-second lead time is hugely helpful in these kind of situations. It just stinks to be in our call room, which is literally a floor above where we are. My pager goes off, I run down the steps, and the patient's already on the bed having their clothes cut off, and I've missed a pre-hospital report. It's just... it helps to have just a little pre-notification. What equipment should you have ready? Well, certainly you may have to secure the airway in these situations, so your airway team and rapid sequence intubation drugs should be available readily. We use quick look paddles pretty liberally to screen patients for a cardiac rhythm that would lead us to an ED thoracotomy in select patients. So it's nice to have those there. We're not going to talk about ED thoracotomies and indications for that in this talk at all. Chest tubes, chest tube trays, Pleurovacs with auto transfusers available. We have our ED thoracotomy bay very close in our trauma bay because we never know when we're going to use it. And of course, some element of uncross-matched blood available to start resuscitation as early as possible. When patients arrive, if there's a pre-hospital report, if the patients came by our EMS system, we can get a quick report from them. We like to use sort of the MIST system that I know is used, I think, in Australia and some European countries. Just give us a quick mechanism, what the injuries are that you saw, what signs of injuries they had, and what treatment, if any, that you've provided the patient. It's a quick way to sort of to give your pre-hospital guys some respect, listen to what they've done, get some information, and then move on with caring for the patient. Listen to the patient if you get a chance. Sometimes they can give you a little bit of a report as to what happens. If they say, I'm going to die, they are scarily predictive. Their positive predictive value of that is not something that I like to admit to them, but it's pretty good. And just remember, from learning the hard way, that the concept of I can't breathe in a patient who has a normal chest x-ray is very interesting. Usually what that represents is a patient who has a significant, very significant metabolic acidosis, and their sense of can't breathing has nothing to do with their airway or their breathing. It has to do with their circulation. So that I can't breathe, I can't catch my breath is not somebody who's been shot in the abdomen and is having an asthma attack. It usually can be an ominous sign. So we, of course, go through things in the traditional ABCDE fashion. It's listed here on this slide. We'll talk a little bit more about airway a little later on in this session. From a breathing standpoint, you want to triage quickly if their physiology is poor. Decreased breath sounds with abnormal physiology is going to merit some pleural drain. I'm not going to comment on what kind we do because Peter Ree won't beat me up. From a circulation standpoint, if they're in shock, you're obviously going to the OR most likely in those patients. You want to do a disability exam very quickly. If a patient is not moving their legs, that is a trajectory point. Somewhere their spinal cord has been injured, and if you have a wound and a patient who's not moving their legs and has a sensory level, you can have a sense of trajectory before you even get x-rays on a patient. And when you expose the patients, we tend to expose patients very, very early, roll them off that board, in part because we're looking for other wounds. We mark all our wounds with paper clips. We want to do a rectal exam, making sure that we clean the perineum very, very well and make sure that our glove is clean when we place it in the rectum. If you have a bloody gloved finger and you put it into someone's rectum and you pull it out, it will still be a bloodied gloved finger and it won't mean anything on your exam. So just try to take some time there, but if you have one on your rectal exam, that might be another trajectory point for you as well. Again, we mark wounds with paper clips. You can sort of see from this slide, we tend to use regular paper clips on anterior wounds and open paper clips on posterior wounds to try to give us some trajectory determination when we look at x-rays. And when people have multiple wounds, they end up getting paper clip toxicity, but there's not much we can do about that. If anybody ever gets shot with a paper clip gun, it's going to be trouble in our trauma. They won't know what to do. From a secondary survey, we look at patients very quickly. We look for extremity wounds as well. Sometimes patients only have torso gunshot wounds, but in our environment, people are using semi-automatic handguns, and they tend to have multiple wounds, and we need to identify them all. If you can, try to look under that arm as the blood pressure cuff is being placed. If you haven't had that luxury, you might need to take that blood pressure cuff off and make absolutely sure you're not missing a wound. You want to check pulses briefly, and you're looking for some gross abnormalities at this time, obvious fractures you want to try to align. And then we tend to do 3 plain films of the torso. We'll go over that in just a second. And then we also do FAST on all our patients, so we'll talk about that as well. Now, it's certainly appealing to do a chest x-ray and an abdominal x-ray as a way to screen a patient. And this is a chest x-ray where you can see the pleural space, you can see the cardiac silhouette, the basis might be cut off a little bit, you see some of the lower neck, but it's a very reasonable film. And what's nice on this patient, you see sort of the extra pleural, extra ribcage spaces both on the left and right of the patient. And then if you add an abdominal film to that, it looks pretty appealing that you've imaged the entire torso on my little cartoon there. And this is an example of a film here where someone has some broken ribs and some paper clips from multiple torso gunshot wounds. Now you can see even in this that you've missed sort of the flanks on this picture and you've missed maybe the lower pelvis. I don't know about you guys, but many of our patients in Philadelphia look like this guy. And this concept of shooting 2 films with them taller than they are wide is really going to leave a lot to be desired if you're trying to identify wounds and retain foreign bodies so you can try to put things together. So we tend to shoot, and this is just an example of someone who had an abdominal film. He had a right upper quadrant gunshot wound, and we had the hint that he had a number of other projectiles down in his abdomen, and he, for many reasons, subsequently went to CAT scan, and this is his scout film, and that plain film not only missed all of his shotgun wound pellets from a prior interpersonal negative relationship that he had, but he also had, he had other bullets down in his, he had all kinds of chaos going on. Thankfully, that was all from previous events. All we needed for him was to, swallow a hand grenade, and he could have all kinds of shrapnel in there. But anyway, these films, again, don't give you all the pictures. So we tend to shoot 3 films laterally. We start with a chest x-ray, because if there's one film that I want to get on a patient who's shot in the abdomen, I sort of want a chest x-ray. I want to know if I'm going to have to perhaps go into his chest, go into his pericardium, do something while I'm concentrating on a lot of injuries in his abdomen. And as Dr. Holcomb talked about in his talk about the hybrid OR, that putting up that balloon to give you proximal control of an aortic injury sort of relies on the concept of you having a normal chest x-ray and no shenanigans going on above the diaphragm. So we tend to shoot these 3 films. I'll show you a couple series of patients with a chest x-ray, an abdominal x-ray with a retained foreign body, and a paper clip where the entrance wound was in this patient who was only shot once. Another series, chest x-ray, abdominal x-ray, and a pelvic x-ray, just sort of to triage the entire torso. And on occasion we do a lateral film. It can give you some insight into where the bullet is. And again, if you can find the paper clip and line up a trajectory, you can have a better sense of whether your intraperitoneal, your major vascular structures, all those things are injured. And one final example, this is a great approach. It is not foolproof. This is a patient who had multiple torso gunshot wounds. You can see maybe on this, he's got a paper clip over here and a foreign body here. They line up. He's got a paper clip here. He's got a paper clip over here. He's got another foreign body here. He's got more wounds and more bullets in his pelvis. He ended up going to the operating room and having abdominal injuries taken care of. And on a post-op CAT scan, he had a paper clip up here in his neck. And actually that left chest gunshot wound was the trajectory that went up to his left neck. So even imaging a chest, abdomen, and pelvis might leave you wanting in some of these patients. There are some people who have used something called a LODOX scanner. It's sort of a total body CT scout, for lack of a better term. It's a low intensity x-ray that supposedly was developed in South Africa to screen people for swallowing diamonds in the mines and trying to smuggle them out in their GI tract. And some people have talked about using that in these kind of patients to sort of in one quick shot screen patients for foreign bodies where they might be. Now it's imperative you sort of get a chance to ask people who've ever been shot before. We like to have the paper clips in place in the trauma bay to sort of help things out. So to that end, again, we talked already about Mike Rotundo's comments about trajectory determination. The other thing that's very important is that in general, the number of gunshot wounds and the number of foreign bodies that you see on your x-ray should equal an even number. Everybody got that? In general, if I shoot you, I'm not going to do it. The bullet will go in and come out, and you'll have 2 holes. Or the bullet will go in and stay in, and you'll have 1 hole and 1 foreign body on x-ray. If they don't equal an even number, then you need to consider you're missing a wound in a hair-bearing area between the buttocks cheeks. Someone maybe's been shot in the mouth. Someone's been shot in the anus. We've actually seen that. You might be missing a bullet. You have one of those x-rays that doesn't show the love handles on a large patient. You could have a bullet over there that you're missing. Or increasingly something that we have seen for many years, the patient's been shot before and has a retained foreign body. And usually patients, if they're awake and can talk to you, can tell you that because they know it almost like a badge of honor. They know they've been shot and they have a bullet, and they'll tell you where it is. So patients still come in, they're shot certainly many times, and they can be a challenge to sort of sort out. This is a patient who had I show this because this patient was shot down in the pelvis, was hypotensive, had a lot of bullets and trajectories down there. This was a plain film that was shot after the operating room. He already has a damage control dressing on. And the reason I show this is because the one film this patient got that helped them go to the operating room confidently was a chest x-ray that showed that the mediastinum, the cardiac silhouette, the pleural spaces all looked okay. And even though they prepped it in the field because we're sort of creatures of habit. We do the same thing all the times on these patients. You know, they felt pretty confident they were not going to have to go into his above his diaphragm to deal with any injuries. Now we'll talk about a fast exam pretty quickly. I think this is a film I actually stole from Heidi Frankel when she was at Penn, when she was 17 years old. Is that right, Heidi? I think that's when you started there. We do a fast exam on everyone. I mean, if somebody comes in with a bowling ball injury to the foot, we are going to fast them because I think the more we do it, the more we get better at it. What really I think helps is seeing more positive exams. We have plenty of people that we see negative exams, and hopefully we get good at it. The question is, are we going to get better and better at picking up positive exams? And for us, the most bang for our buck we're going to get is, for positive exams, is somebody who's shot in the abdomen. Though, you know, short of going to the pre-op liver transplant floor and fasting people up there with known ascites, you know, these kind of patients that wander through our trauma bay are great to see positive exams. So we absolutely encourage everyone to look at these exams. We try to videotape them for PI purposes, and it's really a nice way to improve your skill set. If you have a positive FAST, it's really pretty predictive. I'll show you one at least study that shows that it's not a bad way to sort of tighten your sphincter and get a sense that you need to move this patient along to the operating room. A negative FAST is absolutely not predictive. You need to keep churning with those patients. Your still approach should be, I'm going to the operating with them until more and more data comes in that maybe forces you away. And again, any residents in the audience, what do you tell your oral board examiners? I would be hesitant to say you fast someone with penetrating abdominal trauma. If it's some old guy who's not a trauma surgeon, he might not like to hear that answer. This is one story that's out there. There's not a lot on penetrating torso trauma because everybody knows you could have an injury to the bowel and not have a positive fast, and that patient's going to need a laparotomy. But it certainly senses that the specificity of this, if it's a positive study, it's a pretty good predictive value. Now, I'm going to go off on a tangent here for just a few minutes and talk about the concept of mandatory laparotomy, because, again, we mentioned at the front of this that you're taking this patient to the operating room, and that's the approach you should have for these, and that's the approach we try to teach our residents and fellows, that somebody comes in with a gunshot wound to the abdomen, you're taking them to the operating room very, very quickly. And only perhaps as you get more and more data do you very slowly walk away from that. The history of mandatory laparotomy goes back many years, largely led by data from the military, from different conflicts that have shown that with an approach of mandatory laparotomy, in general, abdominal gunshot wounds have been associated with a decrease in mortality, along with a lot of other improvements in patient care. So when I try to think about mandatory laparotomy, I, in general, knock it down to 5 basic reasons why we might do this, and we'll go over these 5 in just a little bit. Now, there's a plus side to mandatory laparotomy. In general, the incidence of intra-abdominal injuries after someone's had a gunshot wound to the abdomen is very high, and it's certainly been reported that a number of these patients have an unreliable physical exam. I think Dr. McCursey yesterday mentioned the concept of his residents. He always found the fact that his residents were amazed that they opened up somebody and a bunch of blood poured out, and they said, oh, you didn't have any pain beforehand. Maybe there's some substances involved in some of these patients. Maybe they have concomitant head injuries. Maybe just some blood in the peritoneum for every single patient is not necessarily going to cause them to have peritonitis. Now, there's a plus side to mandatory laparotomy. Ideally, we'll do a good, thorough exam and not miss any injuries. Now, we all know that's not 100% true, but it's pretty true. Hopefully, if we look everywhere, look in the lesser sac, expose things, we'll pick things up. Though ideally be no delay in diagnosis. Somebody comes in, gunshot wound to the abdomen, we take them to the operating room. No delay. Maybe that would minimize contamination, minimize transfusion, allow us to do more definitive repair at the initial operations. Certainly our residents would like it because they would get to operate a bunch. And again, for the residents, I think it's the oral board answer. But there's a history of selective laparotomy that dates back more than 50 years. It started with stab wounds, where they decided, it's a study from 1960 from New York City that looked at peritonitis, peritoneal irritation, as the deciding point to take somebody to the operating room, and they decreased their non-therapeutic laparotomy rate from 34 to 7%. I'm just going to take 1 second here to make 2 definitions clear for everyone. A negative laparotomy is a laparotomy where no injuries are identified. A non-therapeutic laparotomy is a laparotomy where maybe you find injuries, but there's nothing surgically to be done for them. So an example would be a stab wound to the liver. That's an injury. If you lap somebody, you look at the injury to the liver, there's a stab wound, it's no longer bleeding. You give each other a high five and you close. That's a non-therapeutic laparotomy. It's fun, but it's non-therapeutic. Other things besides just physical examination have been done with stab wounds. People have looked at diagnostic peritoneal lavage and local wound exploration. All of these have further decreased the non-therapeutic laparotomy rate. But we all know stab wounds and gunshot wounds are different animals. They're similar animals, but they're different animals. In general, if I stab you in the abdomen, if I shoot you in the abdomen, the chances that the foreign body, the knife or the bullet, are going to penetrate the peritoneum are much higher with a gunshot wound. And if you penetrate the peritoneum, the chances that you're going to need surgical intervention historically are much higher with a gunshot wound than a stab wound. So we'll talk about these five justifications. We'll talk about injury identification. Well, when I turn up the HUP, another thing that my mentors tried to teach me is that we should maybe use something to get a sense where that wound, where the direction of the bullet was. And they actually talked about using something like a blunt probe. And I got to tell you, I felt like the handsome guy in the middle. And those other 3 guys are Mike Rotundo, Bill Schwab, and Don Cotter, trying to teach me that I could gently take a sterile needle clap and let it drop into the wound and get a sense if the bullet was going straight or at an angle. I never really drank this stuff in the test tube. I'm not really sure. I'm not sure it can determine trajectory. It can't. There's actually a study out there. It can't determine peritoneal penetration. This is a study. I will only say I found it when I was reading as a fellow selected readings in general surgery, the section on trauma. It was a study where they anesthetized an animal, stabbed him multiple times in his abdomen, and then probed each of the wounds, and then did a laparotomy to see if the probing accurately determined which of them were full thickness and which of them were not. And the bottom line, it was not very helpful. So I'm not a big prober for these wounds. DPL is another option. It can't determine trajectory. It might give you some information about peritoneal penetration. There's some studies or some centers out there, especially in the Chicago area, that still do a modest number of DPLs for penetrating trauma. They use a red cell count as a positive threshold that's much lower than 100,000 red cells per cubic millimeter that is talked about in ATLS for blunt trauma. And it certainly doesn't identify injuries. It just tells you there's some blood in the peritoneal cavity. And these are some of the studies that have looked at this. It's talked about being very useful. We tend to not use it. I'm not sure, we know how to do a DPL anymore. We do it so infrequently. We do it on occasion, and we certainly have had some false negatives, as Dr. Holcomb mentioned in his talk. But we don't do them a lot, and it's something almost of historical injury. How about laparoscopy? Well, it might be helpful in patients where you have a possibility of a tangential gunshot wound. Many of our patients have a number of inches between their skin and the rest of their abdominal wall, and the possibility that a patient who has two holes, one in his flank and one in his anterior abdomen, that the bullet went tangentially is possible. There might be a role for laparoscopy. From an argument's sake, you could say it's still surgery, but it's certainly less than a laparotomy. And there's a number of patients that have looked at this for tangential wounds, for people who are stabbed in the left thoracic abdomen, especially to look for diaphragm injuries. There absolutely is a role for that. And then how about CAT scan? CAT scan in general, in the right patient population, maybe it can determine trajectory and show you there's peritoneal penetration and be helpful in a tangential gunshot wound. It also can show you injuries in solid organs. And there's a number of papers, there were a spate of papers in the end of the last century that looked at this. And this is an example. This is that one case I showed you earlier. This gentleman had a prior laparotomy for all those things that were involved in his pelvis. He was hemodynamically stable. We booked him for the OR, but he was hemodynamically stable again. And some of these papers had just come out. This was a patient I took care of in the mid-90s when I was at Penn, and we ended up taking him to CAT scan because I was heard about this. And this was his gout, and this was the trajectory that he had through his liver and through the top of his right kidney, away from his duodenum, away from his hepatic flexure. All the stuff in his pelvis turned out to be old. He ended up telling us, and we ended up being able to manage this guy expectantly. How about this concept that gunshot wounds have a prohibitive rate of visceral injury? Well, it's certainly thought to be high. I mean, I think it should be high. But even dating back to Vietnam, the registry out of Vietnam suggested there was a 20% negative laparotomy rate for people that had penetrating trauma to their abdomen. And the rates of negative and non-therapeutic laparotomies in the civilian wounds is certainly substantial. Delays to the OR equal increased morbidity and mortality. There's a number of exams, a lot of these from Dr. Dimitriadis and his group when he was in South Africa and subsequently at USC, that shows that actually watching patients doing good serial exams in a well-structured environment is not associated with an increase in morbidity or mortality. And the largest series that they published was I can't believe it's 10 years old now, from USC, lots of patients, almost a third of them observed, only 10% of them required late operations. Complication rates were very low. One patient did get septics and developed ARDS, but in general it was thought to be a relatively safe way to go. From a laparotomy standpoint, as surgeons, we all know everything we do is perfect, but clearly there's morbidity associated with it. We heard it in one of the resident paper competitions this morning. There's multiple associated complications, as you can imagine. Atelectasis, pneumonias, wound infections, DVTs and PEs, and the concept longer term of problems with adhesions and obstructions. The morbidity mortality rate for some of these things range widely in the literature depending on how you define them. The one I like to pimp my residents and fellows on is this prospective database from Emory that is very conservative in their definition of complications, but showed a 40% complication rate in patients who had a negative or non-therapeutic lumped together as the term unnecessary laparotomies. And again, the studies out of USC have suggested that a therapeutic laparotomy obviously has a significant complication rate because of all the damage that goes on inside the abdomen, but a negative or non-therapeutic laparotomy still had more than a 25% complication rate. And finally, there's no economic and social costs. Well, obviously that's not true. This is more data from USC that shows that the charges associated with a negative or non-therapeutic laparotomy are substantial, and that if you multiply this by many, many patients, the savings would clearly add up. And that doesn't even go into how long somebody who had a laparotomy versus being observed would be out of work. And again, when they do the math and multiply lots of patients by lots of numbers, you end up with a really, really large number, $10 million in hospital charges, not costs, charges saved in that study. So what does that mean? It means that you still need to plan on going to the operating room. Please go away from this with that thought. But as you get more and more data, maybe the potential for you to approach the patient a slightly different way is there. If they're unstable, they have peritonitis, operating room, unexaminable, operating room, limited resources to do these swell hourly physical exams, operating room on these patients. If they're stable, if they're examinable, maybe there's the potential to do some trajectory determination, figure out if there's peritoneal penetration and go from there. Laparoscopy might be good for tangential wounds and maybe in the left thoracal abdomen if the only concern you have is a diaphragm injury. CAT scan might be good in the back or flank in the right thoracal abdomen, and there are some studies that have looked at it in the pelvis as well. And again, the options from this are nice. From a CAT scan, it not only gives you information, maybe it tells you something about solid organ injury and gives you some other options besides simply operation to repair them. So let's talk about some very practical issues as we wrap up here. If you're going to consent the patient, if they're awake to, consent them for a possible colostomy. Nothing worse than a patient waking up surprised that they have a colostomy. So if they're awake, let them know it's a possibility. You'll do everything possible to keep it from happening. They actually usually have more concern about that outcome than any other outcome. But talk to them about it. Antibiotics, start them before you go to the operating room or as you're making your incision. Stop them promptly post-op. Even if you have a hollow viscous injury, long courses of antibiotics are usually not necessary in the majority of these patients. Tetanus shot, if it's clear that they're up to date, fine. If not, give them a tetanus shot. Nothing wrong with that. And then book them to the operating room. We do the vast majority of our patients as now emergencies. We call the OR. We're coming up. We have a staging system for all operative emergencies up there. Occasionally somebody who's new to practice gets trapped into calling somebody a hot operating room, thinking they'll be up there in less than 2 hours. In general, in our institution, a hot operating room that gets you up in less than 2 hours gets you up in 1 hour and 59 minutes. So it doesn't fall off their radar screen as a bad outcome, but it's that's a delay our patients really don't need. When do you intubate these people? Do you intubate them in the trauma bay or intubate them in the operating room, trauma bay or operating room? You have to decide what your comfort level is at both of those levels. This is some data as we transition from emergency medicine to anesthesia, being our airway team in our trauma bay. And again, the success rates really are pretty good. If you go up to the operating room, don't be surprised that your anesthesia guys want to talk to the patient. Have they ever had malignant hyperthermia? Have they ever done anything? Consent them for the surgery. And it's the term that's out there is the obligatory anesthesia fooling around time, the OOFAT. You need to be aware of that. Nothing frustrating that you rush somebody up to the operating room to not have them asleep for 25 minutes. It really is it's whatever. So you need to sort of pick your poison and figure out where you're going to intubate somebody. When you talk to anesthesia, though, usually we talk to them on the phone as we're getting ready to come up. We have a formal process to communicate with them. We use an A, B, C, D, E. We're just very simple people. A, are they intubated? And if they are, some issues about that. B, do they have chest tubes in place? C, physiology and IV access. What do they have? What was our blood request for the patient? D, our neurostatus in the trauma bay before they went to sleep, if they've been intubated downstairs, and the location of the suspected injuries, realizing you don't know totally. Again, we tend to be liberal with our trauma exsanguination protocol. I'm not going to talk a lot about this because we have some experts here who have already talked and are going to talk later on in this conference about them. We use one phone call and get a perfusion team and all kinds of things. We are lucky enough to have stored plasma. It was actually something when we started our trauma exsanguination protocol now many years ago, our blood bank suggested. We didn't suggest it. They suggested it. We're lucky we work in a very busy institution in general, and they're able to turn that stored plasma over continually and never really throw it out. And we use it now for some other uses, not just for our trauma exsanguination protocol. And, we've looked at, this is our little retrospective data. The ICU always seems to be a time, regardless of whether we're doing a study or not, where we get new labs. And certainly as we brought our trauma exsanguination protocol line, our post-operatively, our labs in our abdominal trauma damage control population that Mike Rotundo studied in 88 to 91, and we restudied again in 97 to 2000 were much improved, and our mortality was much improved, or survival improved, whichever way you want to look at it. There certainly are other things that you could be doing. Following resuscitation closely is certainly the wave of the future. Having a TEG and knowing more exactly what products to give, and even relying less maybe on than the ratios that we talked about earlier this morning is going to long-term be the correct way to approach these people. Do they need TXA therapy? Do they need PCC therapy, as we heard one of the residents speak about yesterday? All those things are important. Remember, if your patient's losing a lot of blood and you're turning it over, often their antibiotics are being washed out with everything else, and you might need to redose antibiotics sooner rather than later. Once you get up to the operating room, you want to position the patient, obviously. If you have chest tubes and a Foley in, you want to make sure that those things go up to the head of the bed, and you remind anesthesia to follow them. A bad outcome I recently had was a patient who fell a huge height, had a hemothorax with 100 cc's of blood out, and a chest x-ray afterward. It looked pretty good. He had a lot of abdominal injuries. We went upstairs. He was not doing well. I thought it was because of the concomitant head injury he had. We took down the drapes, and he had a pleurovac full of blood. And because we did not put it up at the head of the bed and tell the anesthesia to watch it for us, we missed it. And by the time we got into his abdomen or into his chest, we ended up not doing very well. Most of our patients will do supine. If you have a concern for thoracoabdominal gunshot wounds, we'll put them in what we call the modified taxi hailing position. We put sort of a roll, try to keep them in some kind of spinal precautions, put a roll under their side, have their arm up as if they were hailing a taxi, and it allows us, when we airplane the table, to do a laparotomy or do an anterior lateral thoracotomy with a little bit better exposure than just being prone on the table. So we put many of our patients in this position. If you have a pelvic gunshot wound, don't be tempted if you have a resident who says, listen, I just came off my colorectal rotation. Let's put this patient in lithotomy, put their legs way up in the air. That's always concerns us, especially if we have no preoperative imaging except a plain film. If the patient ends up with a pelvic vascular injury, you might be operating uphill, or even trying to access their groin in something that is now has a crease in it and points up. So we really don't try to do this. If during the case, for whatever reason, we have to do a rigid sigmoidoscopy, we'll just stop the case when we're happy that there's no more bleeding or anything. Put a towel over the abdomen, drop the end of the table, look up with a sigmoidoscope, put it back down, and restart our cases. And finally, the incision, my last slide, I think, is, we favor abdominal exploration first, and someone has thoracoabdominal injuries. Hopefully you have chest tubes in, and they can at least give you some insight into ongoing bleeding. The abdomen, to me, is a big black box, and you have no idea what's going on there. And if you get stuck in the chest doing something, you have no idea how much bleeding is going on in the belly. So we tend to explore the abdomen very quickly first. If there's not much going on, we throw a pack in and go on to our next incision. Chest tubes are used for pleural issues. Transdiaphragmatic pericardial window can be done if there's a question about injury there. If they have extremity wounds, be careful not to drape them too well and forget about them. Patients who are in shock tend not to bleed too much from some of these wounds. As you resuscitate them and are doing things in the abdomen, sometimes all of a sudden there's a pool of blood from the injury in the leg or the arm that you now held under a drape. So you need to make sure that you're keeping an eye on those things. We tend to use a generous midline incision in most of our patients. If they've had a prior midline incision, it's a real crisis. Sometimes we'll use a chevron and give them what we term the cross of death. Get in laterally and try to take the adhesions down medially very quickly. But that can be a challenge. And then you get up to the operating room. Once you get in, listen to all your other presenters today. They're going to give you a lot of information about where to go from there. So in summary, plan on going to the operating room with these people. Rapidly and systematically evaluate them. The physiology will help you as you interpret the data as it's rapidly coming in. Synthesize it. It's most likely going to lead you to the operating room. If everything is checking out fine, a patient is stable, there's a concern about a trajectory that's extraperitoneal, all these things are playing out for you. Maybe you can very slowly step away from going to the operating room, but again, plan on going to the operating room. Thank you very much.